Hi, I'm Dr. Stephen Bradley. I'm an anesthesiologist. I'm also a clinical medical ethicist. I am here to talk about the continuation of my journey within this medical specialty. A lot of misconceptions about anesthesia. People don't really understand what we do as anesthesiologists. Anesthesiologists are physicians. We've completed medical school. We've completed a 4-year residency in anesthesiology. During that residency, obviously, we learn about and practice taking care of patients, providing anesthesia for surgical procedures, which is putting patients to sleep or basically just keeping them comfortable and safe during whatever procedure they may be having. What a lot of people don't know is that we are actually specialized in anesthesiology, critical care, medicine, and pain management. Over that 4-year residency, we get extensive training in managing critically ill, very, very, very sick patients, as well as providing all manners of pain control and pain relief. Despite this already rigorous and extensive training, there exist additional ways to further our medical education and additional board certifications. So at the end of residency, you can come out, you can take your anesthesiology board exams. The first exam is kind of an advanced written exam, which can happen about a month or two after you finish residency. Once you pass that, about 6 months to a year later, you can go and sit for your oral board exams. The additional training I mentioned is subspecialization. So there is pediatric subspecialization, there is cardiothoracic anesthesia, there's pain management, there's regional and acute pain management, there is critical care medicine, obstetric anesthesia, and I'm probably missing a couple. These programs are all 1 year long, and you receive extensive training in those specific areas. I am currently embarking on my fellowship in critical care medicine. Now, my story, I did medical school at Howard. I went to the University of Chicago Medical Center for anesthesia residency. During residency, I actually swore into the Navy for mostly personal reasons. My dad's a retired naval officer. My little brother is in the Navy on active duty as well. So I really wanted to serve alongside my family members. Since I joined the Navy in residency, I kind of had to ask their permission about the next steps. So that the time where I would otherwise be applying for fellowship, I had to get in touch with the Navy and ask their permission to proceed. At the time, which was 2018, they said no, there was no extensive need for critical care trained anesthesiologist. So I completed residency, moved to Virginia. Naval Medical Center Portsmouth was where I practiced for the last 4 years. It's a large military treatment facility, one of the larger uh, Department of Defense hospitals. I was fortunate to see some mild or moderate complexity in cases. I did work with resident physicians, student nurse anesthetists as well. So there's an educational component of that. I have now completed my service obligation, or I will in a couple of weeks. I'm currently on terminal leave, and I have returned to training after 4 years of practicing as an anesthesiologist. So the big question everybody has is why? Why, after practicing, did you come back to training? So it goes back to my time in medical school. As a first generation medical student, I didn't really know what specialty I wanted to go into. I didn't know the options that I had. I do distinctly remember rounding in the surgical ICU when I was on my surgery rotation. Because again, as medical students, you rotate through all these different subspecialties of medicine. Um, I remember being in the surgical ICU and watching Dr. Saram. He's one of our surgical ICU attendings and trauma surgeons at Howard University Hospital. And he just knew so much about each patient that we rounded on. I looked at him and I said, one day I want to be like that man or that woman. Dr. Wendy Green was another one of our surgical or one of our trauma surgeons. And I really took advantage of that as a medical student. It was our trauma service would have patients in the ICU as well as on the wards, and I would seek out the ICU patients, and they were generally more complex, but I enjoyed immersing myself in that complexity. I was actually leaning towards going into trauma surgery, and because then I knew I could work in the surgical ICUs. I remember working on the weekend with one of the trauma surgeons, Dr. Green. She did a cholecystectomy, and I realized that I really didn't like the operating room. The thought of having to operate to put food on the table for me just wasn't appealing. And she was very kind and gracious. We talked later that day, or maybe a couple weeks later. She talked about the different options to practice critical care medicine, whether through an internal medicine and pulmonary critical care route, whether through trauma surgery or anesthesiology. And that's kind of what sparked my drive to go into anesthesia, is that I wanted to become a critical care medicine physician. I wanted to specialize in ICU. So one of the reasons I chose the University of Chicago was because the ICUs are run in large part, especially at the time, by anesthesiologists, and they just have a huge critical care component of their residency program. So during residency, I did, I think, over 6 months of ICU. We had some moonlighting where I picked up additional time in the ICU, but again, I was unable to complete that fellowship because of my service obligation to the Navy. So for the last 4 years, again, I was practicing as a general anesthesiologist. And since then, now that I've separated, I have returned back to the University of Chicago to complete my anesthesia critical care medicine fellowship. Over the course of the year, the fellowship includes over 6 months in the quote unquote home ICUs, which are the surgical ICU and the cardiothoracic ICU. The surgical ICU gets trauma patients, they get a lot of the organ transplants. They get medically or surgically complex patients that come in for acute care surgery, sepsis. That's kind of what I'll be managing in the surgical ICU. In the CT ICU or cardiothoracic ICU, we get a lot of the post-op, or we get all the post-op transplants for heart and lung transplants. We get a lot of vascular surgical cases, so ascending thoracic, um, the ascending dissections, ascending aortic dissections rather, um, and other things. Patients on VA ECMO, a lot more complex cardiac physiology. The rest of the year includes some elective months on radiology, electives in the neuro ICU. Again, being able to see those critically ill, neurologically devastated patients. There's electives in, you could take an infectious disease, nephrology. There, I may try to set up some transplant surgery electives as well. But basically, it's just a year of an immersive experience in critical care medicine. At the end of that, I can sit for the critical care medicine board exam and become board certified in intensive care. So I'm just now completing the first week of fellowship. It's been a long couple of weeks with separating and completing my military service obligation. And leaving the Navy, leaving the service is a lot harder than it is to actually join or get in to the service. I'll tell you that. So I was doing a lot of paperwork. My wife and I were coordinating our move to Chicago. That was a long story. And then trying to get onboarded at the medical center and get started for fellowship. So that's where we're at. I just finished the first week. I am starting out with a month in the neuro ICU. So it was the July 4th holiday weekend. I actually came to work on Tuesday, which was July 5th. Kind of missed the weekend. Um, Gun and knife violence a lot. The surgical trauma service was very busy over the weekend, as you can imagine, in Chicago. And so I rounded in the neuro ICU for a couple of days. Unfortunately, one of my co-fellows had was out sick, so then I ended up getting bumped over to the surgical ICU for Thursday and Friday of last week, which was fantastic. I was so busy. When I was last at the University of Chicago Medical Center, we had not yet really opened our trauma center. We opened it kind of the last 3 months of my residency, so it hadn't really got up to speed. Now it's the busiest trauma center in Chicago and obviously in Illinois. And so I got bumped over to the surgical ICU. picked up a list. I think we ran between 25 and 30 patients. And so it was my job to kind of learn each of these patients and try and figure out what their issues were and what we were doing to help them from day to day. And then it's a more of a supervisory role where I'm supervising medical students and residents. There's surgical residents in the surgical ICU. There's anesthesia, critical care residents, and emergency medicine residents, all kind of rotating through. So it's my job to kind of coordinate the team and liaise with the attending who is covering the unit at the time to make sure every patient's getting cared for and acute issues are being dealt with, chronic issues are being dealt with, and the trajectory of their care continues to move forward. So that it was busy but great. I think both days came in for turnover at 6 in the morning from the night team. Went to trauma, sign out, and then started rounding. Um, extremely complex cases and patients, and I think left around 6 o'clock Thursday night and Friday night. So had the weekend off, fortunately, and my co-fellow's back. They'll be back in the ICU. And yeah, we'll see what happens. I go from the neuro ICU to the medical ICU, and then month 3, I will be back in the surgical ICU for the entire month and taking care of those patients. So really looking forward to what this year has to bring. It feels incredibly fantastic to be academically stimulated once again. The last 4 years were great. I did a lot of anesthesia in a different environment, different hospitals, um, out in the community. But it's good to be at a large academic center where there is incredibly complex care, where you have to spend a lot of time thinking about what you're going to do. Looking forward to seeing how I'll progress over the next year. Even in the couple of days that I spent in the surgical ICU, I was doing bedside transthoracic echo to look at heart function, and I've actually been reading a good bit already. We'll be obviously be reading throughout the whole year, but trying to get back up to speed. So I'm going to try every week to record a video to document this progress, this journey into the world of critical care medicine, and yeah, I'll have this as kind of a video log, um, that I can refer back to, and maybe help people if you're interested in anesthesia or in critical care medicine. Then stay tuned for more.